All right, everyone, we're going to go ahead and get started. A lot of your upcoming exam covers a variety of topics, but a lot of them are kind of linked to GI, GU, and musculoskeletal. So we're going to break it down bit by bit. So the first thing we're going to go that we're going to just have to unfortunately get used to with this patient population. So with these chronic disorders, just to repeat, a lot of it's going to be focused on our patient education, nursing considerations, et cetera, because these are all just diseases that these patients have that they're just going to live with. So we need to, our goal is going to be to educate, promote medication adherence, and just overall improve the quality of life. So the first thing we're going to talk about is our peptic ulcer disease. Lots of different things can cause PUD, specifically our NSAID use or H. pylori infections. There's a lot of complications. The main concern is our perforation of these ulcers and a couple of our vitamin deficiencies, specifically our B12 deficiency. There's two different ways we can categorize some ulcers. We have our gastric ulcers or duodenal ulcers. And just to go back into your basic anatomy, where your gastric ulcers are, those are where the stomach is. Right below your stomach, you have your duodenum. So this will make sense when we talk about the symptoms. For gastric ulcers, those are ulcers in the stomach. So we're going to have pain after eating food. Why? Because that food goes down the esophagus straight into the stomach. So it's pretty quick that these patients are going to present with these symptoms. Because this pain occurs after eating, they're not going to want to eat a lot because it's going to cause them a lot of pain. But like we know with anatomy, the food sits in the stomach, it starts getting broken down by bile acids. That way it can kind of go out the duodenum into our intestinal tract and continue being digested and have those nutrients become absorbed. So if I have ulcers, if I have duodenal ulcers, my pain is going to be a little bit delayed just because it takes a little bit of time for the food to get there. Usually the pain occurs at night. And something specific about the duodenal ulcers is eating food actually makes it feel better. And this is why these patients won't present with any malnourishment. How we're going to diagnose it, we're going to get an endoscopy. We can also get an H. pylori sample of the gastric ulcers to see if that's really what's kind of eroding these ulcers. You can also do your urea breath test for H. pylori. And what happens with this is that it is positive if my patient releases more carbon dioxide than the baseline. So I encourage you guys to go ahead and review that again. If there's any sort of bleed, this goes for any bleed anywhere in the body, you are going to see that decrease in hemoglobin and hematocrit as well. And if there is a bleed, that's when we're going to see a bleed or perforation. That's when we're going to see that rigid board-like abdomen. So a lot of our PUD meds are going to be the traditional tummy meds we talked about in pharmacology, specifically our H2 antagonists and our PPIs. Good way to remember those is your H2 agonists, those end in tadine, and your PPIs end in prazole. We can also give sucralfate. That's very common. All sucralfate does is it just coats and protects the ulcers from damage. So it surrounds, protects, and allows them to heal. We can also give them misoprostol just to help decrease that gastric acid. Specifically with this med, we're going to want to avoid milk. There's multiple different surgical options, so just keep that in mind. Us as nurses, what we want to do is we want to monitor for perforation. If we follow the ABC, airway, breathing, circulation, this is one of the most important and horrific complications of this. What we also want to do as nurses, we want to prep for an upper GI series with contrast. How we prep for this is that these patients are going to be NPO, and just kind of know that after they've received this contrast, we really want to make sure that we flush with fluids to help kind of get that contrast dye out. A lot of our education is going to be on minimizing those risk factors, so avoiding stress, NSAIDs, foods that upset our tummy, caffeine, alcohol, and smoking. GERD, on the other hand, is more of a functional issue. So with GERD, our LES relaxes, and the function of the LES is to prevent anything from kind of coming back up once it gets in the stomach and settles down. So when food goes down the esophagus, the LES opens, food goes through, and then it closes. It closes to allow those bile acids to kind of work, churn to help digest. But what happens with GERD is that a variety of factors can cause this relaxation, but what happens is that the LES relaxes and that bile acid, stomach acid, comes back up. What we're really concerned about with this is as the acid comes up, it's going to damage the esophagus. And so the esophagus is going to end up undergoing some metaplasia, some different cellular adaptations to try to really compensate for this acid that's quite literally burning their esophagus. They're actually going to be at risk for esophageal cancer, specifically that Barrett's epithelium. It's pre-malignant. So that's something that's really important in managing GERD, is we want to prevent that. Usually they're just going to have dyspepsia. Pain is worse when laying down. Specifically, reflux is going to occur at night because they are lying down. Usually these signs and symptoms happen about 4 or 5 times per week, so it's pretty frequent. If you do an EGD on these patients, you might see that red and inflamed esophagus, but what's really important for these patients is doing that barium swallow study. So with that, you literally just swallow barium, and it allows us to look at the x-ray, kind of more anatomy and function of the muscles. So it's actually going to show and light up all portions of that upper GI tract so we can see the LES relaxation. Again, a lot of it's going to be that diet and lifestyle modifications. We really want to reduce the acid of the stomach so that if it does come back up, it's not going to give the patient a lot of pain. Again, reducing that risk of Barrett's epithelium. They can also undergo a fundoplication for this as well. Really, a lot of our considerations as nurses in the clinical setting is going to be in related to the GI series with contrast. Again, with that, like all contrast dyes, they're really harsh on the kidneys. We're going to want to hold the metformin, flush with water. The contrast in the barium might actually turn their stools white. So just kind of reminding them that, so they're not calling you, panicking you, saying that their poop is white. A lot of it for the patient in terms of education, sit up after eating, remain upright. We don't want to eat right before bed because what are we doing? We're lying down. That's causing the LES to relax. Avoid smoking, alcohol, and really, if you have an upset tummy, 4 to 6 small meals per day is really going to help because it's going to kind of prevent that stomach from filling up super quickly, which can kind of cause a lot of that backflow. IBS, irritable bowel syndrome, this is more of a functional symptomatic disorder, can be characterized or caused by a variety of things. It's just important to know the different categories. If you have IBSD, that's irritable bowel syndrome with diarrhea. IBSC, irritable bowel syndrome with constipation. You can have a mix of DNC. You can have alternating periods, maybe a week of diarrhea, a week of constipation, etc. It's important to know what type of IBS they have because this is going to dictate how we go ahead, move forward, and treat it. So if they're having a lot of diarrhea, our symptom management and medication management is going to be more focused on kind of calming the stomach down, preventing the diarrhea. If they're constipated, we're going to work on treating and working with that, if that makes sense. So they really have a lot of crampy LLQ, left lower quadrant pain, depending on if it's diarrhea, constipation, hypoactive or hyperactive bowel sounds, etc. In order to diagnose, they have two of the criteria, which I listed on the right. A lot of that's going to be just that recurrent abdominal bowel pain. And then what's interesting about this is that whenever we move the bowel, pain and symptoms released. I mean, like physical manipulation. They also have changes in the frequency and appearance of their stools. That's kind of where that diarrhea constipation comes in. So again, if they're having a lot of diarrhea, we can give them Imodium, Psyllium, Alessadron. If they have constipation, we can give them Lubiprostone. However, this can only be used for women, biological women. If you have linaclotide, that you just need to take in the morning. It's all going to help with that constipation. Same thing with our education. If my patient's constipated, what am I going to do? I'm going to increase fiber and fluids and fruits. Reducing alcohol and caffeine is a big one for a lot of our stomach GI issues. And honestly, any chronic disease in general, we want to reduce alcohol, caffeine, smoking, etc. So let's talk about irritable bowel disease. We can categorize IBD into two different type of pathologies. You have ulcerative colitis and you have Crohn's disease. They're really similar in the fact that both of which are autoimmune related. So what do we know about autoimmune disease? There's exacerbations and there's remissions. Usually the exacerbations are in times of stress. But what's super interesting about the body is the body doesn't know when it's stressed out. Am I stressed because I have a big exam? Am I stressed because my parents are fighting? Am I stressed because I have an infection or I ran a marathon? Crazy increase in heat, really cold temperatures, etc. The body doesn't know. So at any point of stress, that's when these patients will experience exacerbations of symptoms. However, when we talk about ulcerative colitis, our issue per se is with the large intestine or the rectum. What's interesting about ulcerative colitis is I can actually pinpoint where in the intestinal tract the issue is. This is really interesting when we talk about treatment. But usually with ulcerative colitis, again, they have that left lower quadrant pain, crampy abdominal pain, exacerbations, remissions, etc. But these patients are going to have a lot more frequent stools, and their stools can be bloody. So we're probably going to want to get an occult stool test. So just kind of keep that in mind. Some treatments, we're going to give them corticosteroids for flare-ups. Why? Corticosteroids suppress the immune system. This is an autoimmune disease. So we need to suppress the immune system. Same thing for NSAIDs, specifically with ulcerative colitis, sulfazine and mesalamine work very well for these patients. Additionally, immunosuppressants, immunomodulators, etc. What's interesting about ulcerative colitis is that because I can actually pinpoint where along the intestinal tract the issue is, if it's small enough, I can actually excise and literally cookie cutter out that tiny little part of the intestinal tract. And I can either sew those two pieces together, or you can place an ostomy. This is the only reason that this is able to be done is because we can actually pinpoint where this issue is. This is because with ulcerative colitis, it's only limited to that large intestine or the rectum. So if we can see where the problem is, we can kind of treat that, not necessarily with meds, but by simply removing the part that's not working. So again, if they're receiving EJD, prep for contrast. If they are to receive an ileostomy, just review your ileostomy care. Keep in mind, Crohn's patients are not able to have an ileostomy. We'll talk a little bit more about that, I promise. But just for ulcerative colitis, I would review some of your ileostomy care. And then think about it. These patients are having lots of runny stool, 10 to 12 stools a day. So I'm concerned for dehydration and some potassium imbalances, specifically hypokalemia. So Crohn's disease. This is where we have that same autoimmune inflammation, but it can occur anywhere along the GI tract, and it will occur in multiple different parts. So think about it, you have inflammation everywhere. This is why an ostomy wouldn't work, because they have inflammation everywhere. If I were to cut out every single wonky part, they would be left with almost nothing, I guarantee it. So what are we going to do for these patients? We're going to prevent exacerbations. The swelling is also through all layers of the tract, so just kind of keep that in mind. With these patients, they're going to have a right lower quadrant pain. That's pretty common. And they are going to have 5 to 6 soft, fatty stools with mucus, because they have more absorption issues because they're having damage all along the tract through all of the layers. So with our Crohn's patients, we're going to see more poor nutrition and weight loss, whereas UC, that's when we see just more stools and blood in the stools. Now we have fat and mucus in the stools. So just kind of keep that in mind for these patients. Again, ileostomy wouldn't work. The only surgery that might help is a stricture relief surgery. But with Crohn's disease, we're going to medication-wise treat it with all the stuff from UC, such as our NSAIDs, our prednisone, our immunomodulators, immunosuppressants, etc. For our Crohn's patients, we want to encourage small meals that are low in fiber, especially during their exacerbations. And when they are having an exacerbation, we really want to limit what they're taking. Hiatal hernias, there's multiple different types of hiatal hernias. You guys can review sliding, paraesophageal, etc. Our most common ones are sliding and our paraesophageal, though there are many different other types of hiatal hernias. A lot of our risk factors are going to be kind of linked to increased intra-abdominal pressure, such as obesity, heavy lifting, etc., truncal obesity. But with a lot of these patients, they're just going to have a lot of heartburn, dyspepsia, dysphagia, belching, etc. For these patients, you really want to get a barium swallow study so we can actually kind of pinpoint where the fundus is kind of moving, where the stomach is moving, etc. So for our hiatal hernia, again, proton pump inhibitors are very good, antacids are good. The reason that we're getting that barium swallow study is because most likely we're going to go ahead and do a fundoplication where we can actually wrap the fundus around the LES. For this procedure, just know that post-op, they're going to be on a clear liquid diet. We want to avoid straws or chewing gum because we don't want to increase a lot of air into that newly healed area. After they've received their barium swallow study, as nurses, we need to increase fluids, both orally and IV, and we also will usually give them laxatives to help get it out. Patient education is going to be pretty similar to GERD because the symptoms are pretty similar to GERD, so just kind of keep that in mind. Next, we're going to talk about obesity, malnutrition, etc. You guys do have a lot of these slides, so I'm not going to spend too much time going through them, but just know that there's different types of enteral nutrition for the different types of needs that your patient might have. Rates of feeds are pretty important. When you're having a bolus, it's similar to an IV bolus where you're giving them all of their formula all at once, usually over 15 minutes. Before we ever put anything in any of the tubes that they might have, their enteral tubes, we want to make sure that we flush it before to make sure that it's working, and then we need to flush it after to just make sure we kind of clear it out to ensure that patency. And then when you're giving any sort of feed, at minimum, the head of bed should be at 30 degrees or higher. We have intermittent feeds. This is done over a period of time. With these, it's really important to make sure that we are putting the patient in semi-full Fowlers so that they're sitting upright throughout the entirety of enteral feeds to reduce that risk of aspiration. Different types of equipment, I would just be cognizant of what does what. Our Dobhoffs are smallest, so why are we worried about our Dobhoff? Well, we don't want to be crushing meds and putting it in there because it can clog, because see how skinny it is. Our Rompsons can do a lot. Our gastrostomy and jejostomy, those are, we actually go through the abdomen and we place something directly into the stomach. So think about all the concerns around that area. It's an open area. Monitor for infection, irritation, etc. With our jejostomies, we always want to make sure we're turning that tube 360 degrees, and we want to monitor for any sort of leak. When we have our NG tubes, we're at a really low risk for leaks because the tube is going straight through the esophagus into the stomach. Not a lot of area where the tube could become misplaced. But if we're going in through the abdomen, maybe they pulled it, maybe something happened, maybe it was like just not right, it can leak. And if it leaks into the abdomen. So we are a little bit concerned with this. So if you ever see your patient presenting with dyspnea, pain, increased temperature, I'm thinking that they might have a leak. And what do? I stop the feed. If there is a feed going, I call the provider. A lot of our complications, this is like troubleshooting, if you will. So I'd pay special attention to this because as nurses, this is what we're going to have to do. If my tube is not patent, that's probably because I wasn't flushing or I wasn't crushing. So ideally, we want to flush the tube to determine patency Q4 about every 4 hours. And we always do it both before and after feeds. We always have to make sure that we crush our meds to put them through the tube because we can't be sending a whole aspirin pill down their tube. It's not going to work. It's not going to go anywhere. But the caveat with that is we have to make sure our med is able to be crushed. So call pharmacy, talk with them, work with them, etc. What drugs can't be crushed? Our suspended release, our sublingual drugs, those all cannot be crushed. Post-op suture disruption or perforation as nurses, if your NG tube was placed in the stomach, maybe after surgery, and you know that it's held in place by sutures, don't finick with the tube. That's the provider. That's all them. When we talk about overfeeding, this is why we just need to be checking for residual before we administer a feed. We want to make sure that we kind of take our, this is just pencil, but we take our syringe, we kind of put it in and we pull back. What are we pulling back? What are we aspirating? We want to see if there's anything left in the stomach. If I pull back and I have like maybe 50 mLs, I'm just going to kind of push it back through, but I need to document how much residual is left. Now, if I have about 200 mLs of residual, I have a really big problem. If I have more than 100 mLs of residual, I do not want to administer another feed. Aspiration pneumonia is a big one. If you notice your patient aspirates, the first thing we do, we turn off the feed, suction them, give them some oxygen, full set of vitals, call the provider. Refeeding syndrome, this is really a scary issue because it has fatal shifts in fluid and electrolytes. This really happens in a lot of patients that were malnourished, and we've all of a sudden given them a lot of food, their body's just kind of freaking out. So they'll present with confusion, weakness, seizures, etc. When we talk about placement, ideally our gold standard is an X-ray. We want to get an X-ray, especially after it being placed for the first time ever. However, sometimes things can come up. You might not be able to get an X-ray right away, etc. You can auscultate when pushing air through, but it's not really recommended. You will see it done in the clinical setting now. And it's a good way to kind of just make extra sure. But ideally, getting that X-ray is super important. And then we want to aspirate the contents of your NG tube if it's got suction. We're going to aspirate it and we're going to check the pH. If my NG tube is in the right place and it's in the stomach, my pH is going to be very, very low. Why? Because the pH of the stomach is about 0 to 4. A caveat with that. If my patient is on proton pump inhibitors or H2 antagonists, those drugs work by neutralizing the acid in the stomach. So their stomach acid might be closer to 6. So just always assess what drugs your patient's on, et cetera. And that's also why getting that X-ray kind of checks all our boxes. We talked about checking residuals, giving meds, only giving crushable meds, perfect. For the tube, we always flush with 20 to 30 mLs every 4 hours and before and after feeds. So now we're going to talk about obesity, specifically our bariatric surgery. I would just kind of review your different types of obesity. You have your gynoid and your android and kind of what that would look like. Patients who are obese can elect to undergo surgery, usually your gastric bypass. The criteria for this, you have two different things that kind of have to be happening. The first one, if my patient has a BMI over 40, that's morbidly obese. If they have a BMI over 40 and have had unsuccessful weight loss attempts, they will qualify for some sort of bariatric surgery. Or maybe their BMI is not at 40 yet, but they're above 35. If they have a BMI above 35 and they have comorbidities, such as hypertension, type 2 diabetes, heart failure, obstructive sleep apnea, all those kind of diseases, disorders are linked to obesity. So if I have that higher BMI and I have comorbidities, I'm going to make sure that they get educated on receiving some gastric bypass surgery. I do want to talk about this really quick. If you're taking notes, jot this down. Before a patient can undergo surgery, they need to, one, make sure that they're ready to take lifestyle and diet modifications, but you also need to do a full psychiatric eval. If they have untreated depression or binge eating disorder or any sort of psychiatric issues, this would disqualify them from getting bariatric surgery, because I can do the surgery, but there's no guarantee that if we don't help your psychiatric issues that you're going to be successful in the surgery. So we need to take care of that first. Just keep that in mind. Multiple different types of bariatric surgeries. Dr. Rosales did a really good video on it. You can go ahead and just kind of rewatch it. I'm not an expert in the bariatric surgery, so I'm not going to spend too much time on it, but just kind of keep in mind our most common one's going to be our gastric bypass. It's got the most successful rate. Our total gastrectomy, it's not ideal because it does remove almost everything, and usually it's used for patients with a lot of different problems. Complications that we as nurses need to monitor for, dumping syndrome is our most common one. This is usually when my patient eats a high sugar, high carb meal, and it just goes way too quick into that small bowel. Usually directly after eating, then I have cramps, diarrhea, dizziness, tachycardia, etc. So just assess for that. And we'll talk a little bit how to prevent that later. Post-procedure, post any sort of bypass surgery or any surgery with a patient that's obese, they have a lot of fat around their necks. So it can actually kind of put a lot of pressure on their airway. So just really making sure that they have a patent airway post-op. We want to monitor for a leak as well. If they have kind of a leak of where this surgery was done in the stomach, where they've fused the two portions, there can be a leak, and that's when they're going to have more back, shoulder, abdominal pain, tachycardia, etc. You need to call the provider because they're probably going to have to go back to the OR. Atelectasis is another one, and skin fold breakdown. So just kind of keep in mind kind of going through that. Again, part of our education, we want to discuss emotions and coping skills, diet, ideally 6 small meals a day. Their stomach size has been drastically reduced. So they might have been able to, per se, hold, if you have a 32-ounce water bottle, that might be how big their stomach was. Now we cut a lot of stuff, we removed a lot of stuff. Maybe now they can only have 8 ounce, like a little 8-ounce water bottle. That might be the size of their stomach. So just kind of keep that in mind. For the first 6 weeks, they need to be on pureed foods, low carb, low sugar, high protein. They're also going to have, they've had abdominal surgery. So just kind of wear your abdominal binder, splinting for moving, coughing, deep breathing, etc. So short bowel syndrome, I do apologize. The slide did get a little bit messed up where I have 2 of the same slides instead of 1. I will fix this and get this sent your way. Don't worry. But just thing I do want to talk a little bit about with short bowel syndrome is it is a malabsorption issue. So with short bowel syndrome, the patient has a really hard time absorbing water, calories, minerals, proteins, and fat from food. Variety of different causes, usually due to any sort of damage of the intestines, if we've removed part of the intestines, if we have poor motility of the intestines, that's kind of where we're going to see difficulties in absorption, simply because we have less surface area of functional absorbable GI tract. So with these patients are at a lot of risk for some fluid and electrolyte imbalances, mineral deficiencies, etc. These patients, signs and symptoms wise, they're going to present with lots of bloating, cramps, a lot of loose, watery, and fatty stools because they simply have a hard time absorbing fat. Because they're having lots of diarrhea, we really want to make sure we monitor for dehydration, malnutrition, etc. To diagnose someone with short bowel syndrome, we're going to do a fecal fat test, and it's going to be positive. Why? Because these patients simply cannot absorb fat. Just kind of remember that. Again, you can also do a barium swallow study, x-ray, but ideally fecal fat test is going to be super important. Medication-wise, again, our traditional gastric tummy meds, H2 blockers, etc. What we give with these patients in specific is our bile acid sequestrant. This is going to help promote the excretion of bile acids because usually a lot of bile acid gets secreted in the stomach and it helps, our body break down the food. As it goes through our intestinal tract, the intestines absorb that bile acid. So we are kind of harboring all of that. Well, if my intestines aren't really working as well as they should, and I have a malabsorption issue, I need to figure out an alternative way to excrete some of that bile acid. So cholestyramine is a big one for these patients. Depending on how bad their exacerbation is, they might need some IV or NGT nutrition and supplements, etc. But for these patients, we want to make sure that they are eating a soluble fiber diet. Short bowel syndrome is a malabsorption issue. Insoluble fiber is really harsh on the digestive tract. That's why we need to give them a soluble fiber diet. What are some soluble fiber foods? Oatmeals, lentils, apples, oranges, nuts, flax, beans, cucumbers, celery, carrots, all great. So for our diet, like I said, lots of our tummy problems, 6 small meals a day. And again, avoiding high fat, high sugar, high protein, insoluble fiber foods because it's going to cause the stomach, the body to work a little bit harder, and they do have a difficult time with absorption. So moving on from our GI, GU, we're going to talk about some connective tissue disorders. The first thing we're going to talk about is rheumatoid arthritis. We talk a lot about rheumatoid arthritis, osteoarthritis, etc. When we're talking about rheumatoid arthritis, I want you guys to think autoimmune inflammatory disease. So what is causing the damage to my joints and my connective tissue? My body is doing that. It is an autoimmune inflammatory disease. So my body is producing mass inflammation on my joints and my connective tissue. Well, we know that the inflammatory process releases lots of cytokines to the area, etc., that really do a lot of damage. That's what's causing the arthritis. Like all autoimmune diseases, environmental stress, really important for exacerbations. Mitigating stress is going to be very important in mitigating the disease. Lots of complications with this. Why? Because connective tissue isn't just in my joints. It is also in my heart, in my lungs, in my eyes, everywhere. So these patients can have lots of complications elsewhere in the body that's not just limited to your joints. This is why it's a systemic issue. With our systemic issue, this is why they're going to have symmetric bilateral pain. and swelling of the joint. So maybe on both of my hands, I have lots of swelling and lots of pain because it's happening all throughout my body. You're going to have fever. Why? Fever is systemic. It's a systemic issue. You're going to have lots of morning stiffness. They haven't been moving. And we'll talk about kind of education and treatment. But they're going to have lots of morning stiffness, fatigue, etc. When we're diagnosing someone with RA, they usually have that positive rheumatoid factor. So just kind of remember that, highlight that, star that, etc. And we can get that through an arthrocentesis. Medication treatments, a lot of it's going to be our NSAIDs, COX-2 inhibitors, corticosteroids. They all work on suppressing the inflammatory process. You can also give them DMARDs, specifically methotrexate as an immunosuppressant. This does take a little bit of time to work, so just keep that in mind. You can also give them Remicade or some other immunosuppressants. Usually they end in MAB. Again, those all take a little bit of time to work. If my patient's having an acute exacerbation, I'm probably going to give them good old prednisone because this corticosteroid acts really, really fast. You can also do plasmapheresis with these patients, but overall our goal is to reduce pain and reduce exacerbations. So they're on a lot of immunosuppressants. This is an immunosuppressant disease. We've talked a lot about in previous lectures about how we're educating my patient. No concerts, no crowds, no babies, no gardens, no none of that. For activity, these patients actually do benefit with stretching. So anything that's really low impact, stretching and yoga is super important. This might be hard and this might be painful. So just tell your patient, take an anti-inflammatory before doing some activity. When we're talking about how we're managing discomfort, if I have any sort of stiffness, think that my joint is frozen. How do I unfreeze someone? By giving them heat. So if you ever have stiffness, give them a little bit of heat, localized heat, like a nice warm heating pack or a warmed water bottle. If I have a lot of pain and inflammation, well, when we have any sort of inflammation, we're going to have that localized heat. So how do I get rid of that? Cold. You just give them the opposite. So if they have pain and inflammation, give them some cold, like an ice pack. During some acute flare-ups, we can also just help immobilize the joints with some like splints, etc. And then most importantly, these patients are going to have a hard time doing some fine motor skills, especially with the hands. So have them use large muscle tasks. Maybe if I'm applying moisturizer to my face, I'm not going to just use one finger. I might use the back of my hand just because if I got a lot of pain in my joints, the back of my hand's a larger group, less stress, it's going to help out. I included this cute little photo as well. I think it really kind of puts a lot together. Osteoarthritis, on the other hand, I want you guys to think wear and tear. So over time, breakdown of cartilage. A lot of it's due to advanced age, occupation. Our marathon runners usually have a lot of osteoarthritis of the knees just because it's common, it's wear and tear. And over time, these bone spurs do develop and kind of lead to that crepitus. Crepitus is more that like crackling, crunchy, gross sound that you might hear. With these patients, usually that pain and crepitus is going to be with range of motion. You can also see some unilateral swelling of joints. Specifically when we're talking about the fingers, I want you guys to think about Herberton nodes and Buchard's nodes. If I have Herberton nodes, I have some swollen, hard, inflamed joints on the distal part of my fingers. So that's farthest away from me. For my Buchard's nodes, those are on the proximal part of my finger. When you think Buchard, think body. If something is proximal, it is closer to the core, closer to the center of the body. So when you think Buchard's, think body. That's personally how I remember it. Etc. With these patients, they can have an increased ESR, CRP. Those are just kind of standard lab values in your CBC. For these patients, for pain management, we can give them some acetaminophen, which is Tylenol. They can also use short-term use of NSAIDs. We don't want to, for this population, promote a lot of NSAID stuff because a lot of what's going to relieve their patient or their symptoms, we talked about in our signs and symptoms. They were pain with movement. So what are we going to do? We're going to rest. These patients can also have an arthroplasty procedure. So just kind of review your procedures, what you do pre-op, post-op, etc. With like maybe if they had a posterior arthroplasty, making sure that they have that abductor pillow, etc. With these patients, just want you guys to focus on resting relief symptoms. We need to balance rest and activities. I don't want them sleeping all day, every day, but maybe in between some activities, just rest. Lyme disease is a little bit tricky. This is caused by a tick bite, usually a deer tick bite that's been infected with Borrelia. I'm not even going to try to pronounce. I think it's like Bergdorferi. Really common in a variety of states. Florida is one of them. So just think all of your tick prevention, people that go camping, people that go hunting, people that maybe have a deer farm, people that are just out and about in wooded areas are at an increased risk for tick bites. Now, not every tick will infect you with Lyme disease, but we do need to kind of be on the alert. There's 3 different stages. Our localized stage, this happens about 3 to 30 days after being bitten. That's when they have those bullseye rash and some flu-like signs and symptoms. If your patient comes and presents with this, we're going to want to admit them and start them on some antibiotic treatment. But what if they got bit on their back and they can't see the rash and maybe they just thought that they were just feeling a little bit run down because they just had this like camping trip that took a lot out of them? That might be kind of why they might not come to the hospital if they simply miss the first stage. That's when you're going to start seeing some early dissemination, dysrhythmias, dizziness, CNS dysfunction, peripheral neuritis. We're going to start to see kind of like a decline of a lot of the body systems. When someone's in stage 3 of Lyme disease, this happens months to years after their infection, usually can result in permanent nervous system damage and a lot of arthritis. So just keep that in mind as well. Unfortunately, when it comes to testing, usually we diagnose via symptoms. This is because you will not, in a lab test for Lyme disease, you will not show like a positive Lyme disease test until about 4 to 6 weeks after the bite. So if you just came in and to the ER 2 days after and you said, hey, I got bit by a tick, and I do like a full body assessment and I don't see a rash, you have no fever, etc., I might tell you to come home and then educate you. If these symptoms come back, come see us again. Because if I do a lab test, it's not going to work because it's so recent. Antibiotics, ceftriaxone is our drug of choice. Amoxicillin may or may not work. Just keep that in mind. That's why we focus a lot of our stuff for this lecture on education. So DEET repellent is a really big one, light colored long sleeve clothes. That way we can kind of see if anything's jumped on us or anything like that. When removing the tick, we remove it with tweezers, and we do not want to squeeze. We don't want to kind of like spread whatever was left in the tick's like mouth, body, etc. into the patient. So we're really going to want to remove it, and we want to make sure when we remove it all, specifically the head. We want to make sure we got all of it out. It included some extra little information on Lyme disease. This is a question. I forgot to exclude it, but it will be on our Kahoot, so we're not going to worry about that. Now we're going to talk about some diseases that involve dietary management. So similar to our GI, more of our GI stuff. Celiac disease is one of our more common diseases, especially nowadays. Again, it's got that autoimmune link to it. But essentially what happens with this is that these patients, their intestines really can't tolerate gluten. So after eating gluten, they're gonna have a lot of bloating, pain, diarrhea, etc. They usually have some unexplained weight loss. And unfortunately, the only way to treat this is just by removing all forms of gluten, all forms of wheat, all forms of rye, all of it. We're gonna cut it out, and we gotta cut it out for life. If my diet changes fail, I can also give them some corticosteroids, but just keep in mind with that, I really want to make sure I get bone density and osteoporosis screenings. We really want to focus on dietary adherence because there's lots of negative complications associated specifically with cancer. So, disease management, all about nutrition. We're going to want to avoid wheat and rye, and we're going to want to give them their safe foods, eggs, yogurt, potatoes, fruits, vegetables, etc. Keep in mind, these patients cannot have beer. Lactose intolerance, this is an issue involving lactose, not to be confused with someone who has a dairy allergy and is allergic to all forms of dairy. Lactose intolerance is a little bit different because it's just to lactose. Dairy may or may not contain lactose. It depends on what dairy we're selecting. But just know that with these patients, they specifically do not have lactase. So therefore, when they ingest lactose, they cannot break down the lactose. Lactose breaks down into glucose and galactose, and that's how we absorb it. Great, awesome. But with these patients, they can't do that because they have no lactase. Really our signs and symptoms: bloating, gas, diarrhea, just upset tummy after eating lactose. And treatment-wise, we can actually give them like a lactase enzyme in the form of like a pill. If you've ever seen, I don't know if it's called like a lactase pill, but they can actually eat that like before they eat food heavy in lactose, and that actually acts as the enzyme to help break it up. But ideally, we would just want to eliminate lactose. Keep in mind that calcium supplements, Greek yogurt, hard Swiss and cheddar cheese, those are great ways to get in vitamin D, which is something that we need, without ingesting lactose. Those have really, really low minimal levels of lactose, so they're actually pretty good for the patient. However, like full-on milk, sour cream, processed foods, and cheeses usually do have a high amount of lactase or lactose. Now we're going to talk about some foot disorders. Not really much to them. You can have your hallux valgus. It can occur with or without a bunion. The bunion is actually the swelling that kind of occurs on that joint, whereas the hallux valgus, that's literally just my toes drifting. There might not always be a bunion, but usually there is, so just kind of keep that in mind. Hammer toes can be pretty painful and uncomfortable and really limit the patient's ability to wear shoes. Plantar fasciitis, this is really painful, usually common in our runners, people that are athletes, etc., but they're just having this inflammation in the arch. So whenever they kind of move or bear weight, they have a lot of pain. Corns are thick, painful, hardened layers of skin, usually from constant friction. They are different than calluses, where calluses can kind of be treated. Calluses are more just a thickened layer of the skin. We've all kind of had calluses on our feet. How usually if you go, you can kind of like sand them off a little bit, whereas corns are a lot more hardened and kind of a lot like smaller as well, and corns do require some surgery to get rid of them. Ingrown toenails can be an issue. Mainly we're concerned for infection. So whenever we're cutting nails, we want to trim and round our nails, frequent foot care. If it's really bad, they can get surgery. This showed an actual excision of the skin. Sometimes these patients might just have their toenails pulled out. You also have your hypertrophic ungual labium. This is when that toenail becomes necrotic and infected, and we're going to need a lot more treatment for these. So treatment for our bunions, you can do a bunionectomy. This is a pretty invasive, pretty painful procedure. Usually they're going to have pins in place for a while. It takes about 6 or 8 weeks to recover, and they have to be non-weight bearing. For plantar fasciitis, just because it's more of an issue of the arch of the foot, kind of more your tendons, your ligaments, ice, stretching, you can get special shoes, NSAIDs, steroids, just to kind of ease the pain, reduce the inflammation, etc. For a lot of our other diseases, corns, hammer toe, etc., even bunions, hallux valgus, we can actually get personally fitted shoes, special shoes tailored to kind of what's going on down there. Little caveat, healing takes a lot longer in the lower extremities. Specifically, they're just farthest away from the core of the body, so they're going to take a while to heal. Just keep that in mind. Remember that. Big thing, we want to focus on ambulation, ADLs, and safety. So another foot issue, it's not specifically a foot issue, but it's kind of connected, is gout. So what in the world is gout? Gout occurs when our body breaks down purines into uric acid. Fortunately, the uric acid builds up and forms painful, sharp crystals that can kind of deposit anywhere in the body. Usually they do deposit in the foot, and that's what we call our gout attack. So that's why I included it with some foot stuff. Primary can be inherited, like family history inherited. When we have secondary causes of gout, these are from other more complex issues, renal insufficiency, diuretics, crash diets, etc. Those we have like a definitive cause, where when we have primary, we just know that it's inherited. There's about 3 different stages of gout. You have your asymptomatic. If you do a uric acid levels, you'll see that begin to rise. Acute, that's when we have a lot of that pain, specifically in the toe joint. That's kind of more of your gout attack. And then you have like your 3rd stage, which is more of artificious. This is when they have just repeated gout attacks. And then they can actually develop urate crystals under the skin and in the organs. So not very good if we're developing a lot of kidney stones. For gout, some things we can do, pain, NSAIDs are okay. Specifically, allopurinol is prescribed for these patients. This helps us basically stop production of uric acid, and it helps us get rid of it. It must be taken after meals though. So just kind of keep that in mind. A lot of our education, avoiding high purine foods. What are high purine foods? Organ meat, shellfish, sardines, alcohol, caffeine, red meat, dark chocolate, all of it. What are we also going to teach our patient? We're going to teach them to increase their water, avoid aspirin and diuretics. If they can, now if they're in heart failure, might not be doable. We just kind of keep those things in mind. Last thing, second to last thing we're going to talk about is some bone disorders. So what's going on? I wanted to break up some key terms. We talk about osteomalacia. I want you guys to think about vitamin D deficiency. Vitamin D helps our bones become big and strong. If I have low levels of vitamin D, I'm going to have bone softening, lack of calcification. They're going to have decreased calcium and phosphate levels. When I have osteopenia, this is just a categorization that lets me determine what's going on with my patient. So if I know my patient has osteopenia, I don't really know what's going on. All I know is that when I look at their age and their gender, they have a really low bone mineral density in proportion to their age and gender. This puts them at risk for osteoporosis. So let's talk about osteoporosis. So this is a metabolic disorder. Essentially what happens is there's an imbalance of blasts and our clasts. Our blasts build bone, our clasts pull calcium out of the bone. And I do want to talk a little bit about our good old hormone, parathyroid hormone. What does parathyroid hormone do is it puts calcium in the blood by pulling it from the bones. So just keep that in mind for patho stuff. Unfortunately, these patients don't really know that this is happening until they end up breaking a bone. and bone break, fracture, etc. A couple different types of causes are primary causes. These are just more of our aging, dietary considerations, drug use, etc. When we talk about secondary causes, we're talking about specific disorders. I mentioned our parathyroid hormone. If I have any thyroid, parathyroid issues, that's going to affect my bone mineral density because it's going to help pull out calcium from my bones. You just keep that in mind. A lot of these signs and symptoms, just review your spine deformities. I think those are really important to review, specifically some pictures of what those might look like. And really just risk for fractures, etc. Going to want to get a good set of labs on these patients. We're going to see some decreased calcium levels. We're going to see, we can do a T-score, usually anything negative 2.5 and like kind of in that direction, like negative 2.5 and below, like negative 2.5 to negative 5. That's going to be pretty indicative of osteoporosis. So what can we do to help? Well, we can give them thyroid hormone, calcitonin. This helps inhibit that osteoclast activity. So it's going to stop our body from taking calcium from the bones and putting it out to the body. We can also give them some calcium with vitamin D, specifically D5 with citracol. We can give them biophosphonates. Just kind of keep in mind they need to be taken in the morning on an empty stomach. And then estrogen agonists. These are for women because we know that postmenopausal women, kind of those issues with estrogen, with postmenopausal women, that's a really big risk factor for osteoporosis. For your nursing interventions, these patients might need joint repair, vertebroplasty, kyphoplasty. So just review pre-op and post-op considerations. All right, now last thing we're going to talk about is chronic pain. Specifically fibromyalgia syndrome. This is an issue of chronic pain, and it's not an inflammatory issue. Really, we don't know the exact cause. A neurodysfunction is usually like a big link. Some patients actually report before developing FMS in the video you guys watch or will watch. They talk a lot about viral infections. So just remember that. Usually they're going to have trigger points. They have this burning, gnawing, predictable pain kind of wherever they usually experience it. Blurred vision and dry eyes are also very common. And because it's kind of linked to neurodysfunction, you might see more neuro symptoms, difficulty concentrating, remembering, etc. Really, there's no diagnosis for fibromyalgia syndrome. And what we as physicians, nurses, etc., what we do, we essentially just rule out everything else that could be causing the chronic pain. So what are we going to do to treat it? Well, we talked about neurodysfunction. So a lot of our meds are going to involve neuromeds, which I think you guys are just now learning about in pharmacology class. You also talk a lot more about in psych nursing class about some of our neuromeds. Antidepressants work really well, specifically amitriptyline. Anticonvulsants help this population, specifically pregabalin. Selective norepinephrine reuptake inhibitors, duloxetine works very well. Tramadol helps with pain and promotes sleeping. We also give them muscle relaxers, etc. Just keep in mind, a lot of our treatments are neuro-based. What's really important as nurses is to be supportive and avoid stigma. A lot of these patients are categorized as drug seeking, looking for pain meds, etc. So we want to be supportive. The National Fibromyalgia Association is really good with more information. So what do we do for these patients? We're going to promote good old CAM we learn about in patient-centered care, complementary and alternative medicine, yoga, stretching, essential oils, anything that helps them, we're going to promote it because it's chronic pain. Low impact aerobic exercises and stretching are really good, and we want to avoid stressors, specifically alcohol and caffeine. So, if you guys don't have any questions, I'm going to go ahead and share my screen, and we're going to go ahead and start a Kahoot. Just bear with me. This is my first time ever putting like a Kahoot into a little review. I was inspired by Miss Cashman. So I'm going to go ahead and get this shared. So just give me a few minutes. Oh, thank you, Ray. I love goods too. I think they're fun. All right, so I'm just pulling up the Kahoot, and in a moment it will go ahead and give you guys in stuff. Keep in mind, I do have my iPad to the right of me, so I'm able to see if there's any questions in the chat, but because I'm on screen share right now, I won't be able to see the chat on my computer. So if you guys need anything or something's off or you can't see anything, please unmute yourself. That would really help me. I'll give you guys a few minutes just to go ahead and get logged in. And also, I should be recording this as well. That way, for attended today and maybe just want to rewatch the content section, you can watch the content straight through. Or for those that just want to watch like the game, they can just kind of pinpoint in the video where the Kahoot starts. So I thought that that would be a little bit easier and a little bit more accessible depending on which way you guys learn best. Also, let me know if you like this setup, so I can do it for the future as well. So there's about 14 of you signed up. It shows there's about 18 in the review. So I'm just going to wait a little bit more just to make sure no one else is just coming on and no one else is. And then I think you guys should be able to like join after I start, but just in case, I'm going to put it in the chat of what the code is. Okay, awesome. And just to verify, you guys can like see everything okay? If you send the link to your Kahoot, we could find it that way and then play amongst ourselves. I used to use other people. Okay, yeah, definitely after I'll send you guys the link with everything. I'm still learning like Kahoot. I was trying to fiddle it with a little bit earlier. But yeah, I will definitely send you guys the link for it after, of course. I'll send it with like the recording of this video, if that works. All right, everyone, we're gonna go ahead and get started. There's about 40 questions, so bear with me for that. A nurse is checking for residual before administering a feeding via a nasogastric tube and obtains a residual of 150 mLs. What should she do? Should she hold the feeding, reinstill, then administer the new feeding, elevate head bed and administer feeding, discard and then proceed? Awesome job, guys. So we're going to hold the feeding. Since it's only 150 mLs, what we're going to want to do is we're going to aspirate, pull it. We see 150, document 150, then we're going to push it back through. We're going to hold the feeding after. So yes, we do want to make sure that whenever we're administering a feeding, their head of bed is above 45, but the issue is they have a pretty large amount of residual. Anything over than 100 mLs tells me as the nurse, their stomach just needs a little bit extra time to digest before I go ahead and give them more. So they're going to hold the feeding. A nurse is assessing a patient with a bleeding duodenal ulcer. Which of the following findings should the nurse expect? You have increased blood pressure, decreased heart rate, emesis with coffee ground appearance, or bright green stools. Awesome job, guys. You're going to have emesis with a coffee ground appearance. That kind of shows us that there's digested blood. Remember, our duodenal, that's below the stomach. Stomach helps digest. So if there's a bleed down there, some digestion has occurred. So when I vomit it up, it's going to be partially digested blood. A couple of you guys picked increased blood pressure or decreased heart rate. I just want to go over if at any point your patient is experiencing a bleed or a hemorrhage, whether it be from a cut or whether it be from somewhere in the body, a bleed is going to drop your blood pressure. Why? Because we have less circulating blood volume because there's a bleed. Blood is going where it shouldn't be going. In order to compensate for that drop in blood pressure, the heart rate, our heart is going to try to compensate and it's going to increase the heart rate to try to pump more blood out to the body. So just keep in mind, for any sort of bleed, your patient's going to have decreased BP and increased heart rate. If we let that bleed go uncontrolled, your heart rate's going to then start to drop, and then your patient's going to bottom out. A nurse is assessing a patient who is experiencing a perforated peptic ulcer. Which manifestation should the nurse expect? Awesome. Very good, guys. Rigid board-like abdomen. Beautifully done. A nurse is teaching a patient with Barrett's esophagus scheduled to undergo an EGD. What should they include in their teaching? Okay, so we'll go through it. So if a patient has Barrett's esophagus, we know that that's kind of linked to GERD. What is the issue with GERD? There's an issue of the lower esophageal sphincter with GERD. So if I do an EGD, that's just taking a nice little camera scope down my throat, and it's just kind of seeing what's going on. So an EGD is going to determine how well your esophagus works. It doesn't measure the presence of acid in the esophagus. It's just trying to look at that LES and see kind of where we're going wrong. And it's usually just done at the bedside. Can give a little bit of local topical anesthesia for discomfort, but won't be done under general anesthesia. A nurse is assessing a patient with GERD. When checking history, the nurse expects to report that symptoms worsen with. Awesome job, guys. Very good. Bending over. Assessing for correct placement of a nasogastric tube, the nurse aspirates the stomach contents to check for a pH of Awesome job, guys. So ideally, the stomach contents are going to be below 4, 0 to 4. The only time in which the patient might have a stomach pH of 6 is if they're on an antacid proton pump inhibitor, H2 receptor blocker to neutralize the stomach acid. So I think that's why a couple of you guys picked 6. But in the normal patient, like for me, I'm not on any sort of those medications. My pH is going to be around 3.5. A nurse is providing education to a patient with GERD. What food choices should the nurse instruct the patient to avoid? Awesome. We want them to avoid foods high in acid. This one is a select all that apply. A nurse is assessing a patient with GERD. The nurse expects the patient to report which of the following manifestations. Good job. So these patients are going to have a lot of regurgitation and heartburn. These patients do not experience weight loss. They're typically at a stable weight. The only time that we had experienced weight loss was a little bit more with our peptic ulcer disease if they had a ulcer in the stomach, a gastric ulcer. And if you guys have any questions, drop them in the chat. I would be happy to answer them. A nurse is monitoring a patient for the early signs and symptoms of dumping syndrome. Which of the following indicate this? All right, so we are a little bit split with early signs of dumping syndrome. That's when these patients are going to have lots of sweating and pallor. Later on, they're going to have some of that abdominal cramping and pain, but usually your first symptoms are that sweating and pallor. I did get a question in the chat in regards to the previous question. Why wouldn't they have tachycardia from pain? There's kind of two things with that statement. Number one, tachycardia isn't the most effective way to assess if someone is in pain or not. While it can initiate pain, everyone's got different pain tolerances, and there could be multiple different things leading to the tachycardia. That's why it's not super reliable for pain. Additionally, patients with GERD, their pain is more of a discomfort. It's not enough to put them in like really severe uncomfy pain. So that's why tachycardia is really not, number one, a good reliable source of like, are they in pain? But also their pain is pretty mild, I would say. It's more of a discomfort. But yeah, if you guys have any questions about a question, just pop them in the chat. I will do my best to answer them. A nurse performing a Guaiac test on a patient. A Guaiac test is used to determine which of the following. Awesome job, guys. A Guaiac test is used to determine blood in the stool. A nurse is caring for a patient with ulcerative colitis and has been prescribed strict bed rest. Why are they on bed rest? Awesome. So with ulcerative colitis, they're having about 10 to 12 stools a day. That can be bloody, uncomfortable, etc. So that food is going straight through them, straight through their intestines. So what we're going to want to do is to help kind of mitigate that is we're going to want to have them lay down just to help reduce all that activity in the intestines. A nurse is caring for a patient who is having an acute exacerbation of Crohn's disease. Which action should the nurse take? We are going to want to ensure bowel rest for these patients. So in general, with Crohn's disease, we want to educate low fiber. However, if they're having an acute exacerbation, that's when we're going to want to put them on NPO. When they come to us in the hospital, they're in a lot of pain, they're having those electrolyte issues, etc., diarrhea, all that. If it's an acute exacerbation, we're going to put them NPO. But just day to day, that's when we would want to help with the low fiber. A nurse is providing dietary teaching to a patient who has ulcerative colitis. What food selection is best for this patient? All right, yep. With ulcerative colitis, we want low fiber foods. Any sort of like that, like GI going on with lots of diarrhea, low fiber is going to be like the best for them. So all the other foods are pretty high in fiber. Specifically like wheat bread is also really high in fiber. So we're going to kind of do more like of a brat diet. Sorry about that. So for a patient, when they're having an upper GI series, they're usually getting some barium in order to get that x-ray, or they're using some sort of contrast dye. So with these patients, we really want to make sure that they're taking a laxative to help excrete the barium or excrete the contrast dye. And that's when we flush them with lots of fluids orally and IV, and we're going to give them a laxative to get it all out. A nurse is caring for a patient who has an NG tube for intermittent enteral feeds. Which of the following actions should the nurse take? Awesome. So we're gonna make sure we elevate the head of the bed 45 degrees before feeding. A couple of you guys did choose green. Ideally, we would want to flush them with about 30 mLs. But when you're approaching some of these questions, you always follow that airway breathing circulation approach when kind of determining what's the best. So elevating the head of the bed is gonna prevent choking, which is a breathing problem. A nurse is caring for a patient after vertical banded gastroplasty. What should be included in the post-op plan of care? Awesome. We want to support the incision. Very good. A patient with Crohn's disease has had multiple intestinal resections. What indicates short bowel syndrome has developed? Awesome. So it's going to be steatorrhea, which is fat in the stool. This is because when you have short bowel syndrome, you're having a malabsorption issue, especially with fat. So the fat can't get absorbed. It's going to come out in the stool. The nurse will be teaching self-management to patients after gastric bypass surgery. Which info will the nurse include? Awesome. We want to have them drink fluids between meals, but not with meals. This is because their stomachs are super, super small. So they're not going to have as much room for food, specifically nutrients. Water is good, but it provides no nutritional value to these patients. So when we're eating, we want to make sure that we're not drinking a lot of fluids. Also, right after post-op, they're on pureed foods as well. A nurse is talking to a patient scheduled for gastric bypass. What patient findings should the nurse report to the provider? Some history of untreated depression. We need to make sure that we kind of work on that, treat that before we, undergo a life-altering surgery, for sure. What information should be included in the dietary teaching for patient following a Roux-en-Y gastric bypass? Awesome. We want to avoid sugary foods and limit fluids to prevent dumping syndrome. For these patients, we want low carb, high protein. We also don't want them to gradually increase the amount of food to preoperative levels. This is because before the operation, their stomachs were really, really big and could hold a lot of food. But after the surgery, we've literally shrunken the size of the stomach. We don't want them eating the same amount of food that they ate before they had their stomach minimized. So avoiding sugary foods. And remember, carbs are sugars. This one, select all that apply. During a checkup, a patient states they've been having pain and stiffness. What questions should we ask if we suspect rheumatoid arthritis? Awesome. So the two correct answer choices are they experiencing fatigue and fever? And is your pain and stiffness symmetrical in the body? The pain and stiffness for rheumatoid arthritis is actually worse in the morning. So if it were to say, does the pain and stiffness tend to be worse in the morning, that would be correct. But before bedtime, that's not when it's the worst. It's the worst in the morning when the sun comes up. All right. Identify the correct sequence of how rheumatoid arthritis develops. So for this one, it's a little bit more patho, but just so I can kind of describe what's really happening with rheumatoid arthritis is that those kind of antibody antigen complexes are going to kind of attack the synovial fluid, and then the synovial joints. That's why you're going to have that synovitis. What happens with that? Pain and swelling creates a pannus, which leads to that ankylosing. So that's a little bit in detail, but I thought it was pretty cool. A nurse is discussing the difference between rheumatoid arthritis and osteoarthritis. What info should the nurse include? Yep, osteoarthritis impairs a joint on the single side of the body. Our rheumatoid arthritis is our autoimmune process. A nurse is teaching a patient with RA who is prescribed an NSAID. What statement by the patient indicates a need for more teaching? This also goes back to your pharmacology lectures on subnursing considerations of NSAID use. So for these patients, what is contraindicated is taking this medication with aspirin. Aspirin is it's a really harsh drug, so we can't be taking aspirin with NSAIDs. They're going to kind of counteract each other. With NSAIDs, you can take them with antacids. You can crush them, and usually they're going to start seeing that relief in around 4 weeks because it's not right away. A little bit of a tricky question. This one, select all that apply. A doctor suspects a patient may have rheumatoid arthritis due to their symptoms. What diagnostic testing can be ordered? Select all that apply. For these patients, they can get an ESR, rheumatoid factor, and an X-ray. Good job. You're all good, Veronica. I totally understand. When assessing a patient with osteoarthritis, you note bony outgrowths on the distal interphalangeal joints. What are these? Distal. Yep, these are our Herbertin nodes. Remember, our Buchard nodes close to the body. Therefore, they're not distal, they're proximal. A nurse is providing discharge teaching to a patient who has osteoarthritis. What should the nurse include? Awesome. Rest frequently after periods of activity. We want to promote rest, but we also want to balance activity as well. So if we tell them to perform exercises only on days that feel good, well, what if they have no good days? Do we want them being immobile? No, we still want to promote activity, but we're going to balance it with rest. A patient is concerned about getting Lyme disease after a tick bite. What early symptom of Lyme disease should the patient assess for? Awesome, progressive circular rash. It's that bullseye rash. A patient with a family history of celiac disease presents with bloating and pain. What other symptoms will you assess for? Awesome. So with celiac, they're going to have mouth ulcers, unexplained weight loss, and some menstrual irregularities. Select all that apply. You're helping a mom whose child is recently diagnosed with celiac. What food should she avoid feeding her child? Awesome. So we want to, I'm sorry, this should also include rye. I don't know why I didn't select it, but you want to avoid wheat, malt, and rye. Millet is actually a seedless grass, so it has no gluten in it. It's like a vegetable, sort of. Which of the following should be included in a plan of care for a patient who is lactose intolerant? Awesome. So for this one, frozen yogurt can be included in the diet. So if someone's lactose intolerant, they're missing the lactase enzyme, so they therefore have a very hard time digesting lactose. They're not allergic to dairy, so we want to teach them to have foods that still have all the really awesome vitamins and minerals that dairy and calcium provide, but that just don't have lactase. A lot of our frozen yogurt or Greek yogurt doesn't have lactase in it. There are dairy products without lactase. Think you're a lactate milk. It's just milk without the lactase. Gout is a type of arthritis that occurs due to the blank in the blood that causes crystals to form. Awesome, uric acid. Identify which patient below is at most risk for developing gout. Awesome. So it's going to be our obese male who's taking hydrochlorothiazide, which is a diuretic, and aspirin. Very good job, guys. This one, select all that apply. During a home health visit, you're helping a patient with gout identify foods to avoid eating. Select the foods that they should avoid. Awesome. So they should avoid sardines and craft beer. They need to avoid foods high in purines. Sorry, purines, high purines. Parathyroid hormone plays an important role in bone health. When the parathyroid gland secretes parathyroid hormone, it causes the blank. So the correct answer for this, it causes the body to increase serum calcium levels by stimulating osteoclast activity. So what does PTH, do? It puts calcium into the blood by pulling calcium from the bones. How do we pull calcium from the bones? From osteoclasts. They help break down and pull calcium from the bone. Just trying to reinforce the osteoclast versus osteoblast. Our osteoblasts are our builders. Which patient below is not at risk for osteoporosis? Awesome, it's gonna be our 30-year-old male. Very good job, guys. Which occurrence should the nurse expect to assess as a precipitating factor for the symptoms of fibromyalgia in a patient? Awesome job, guys. Viral illness. Select all that apply. A nurse is providing education on fibromyalgia syndrome. What characteristic of pain should they explain to the group? Select all that apply. Awesome. So for these patients, they have sensitivity to stimuli not normally painful, an increased response to painful stimuli, and it's not the result of inflammation or damage. Their pain's kind of more at the core. Last question. A teenager who was adopted at birth presents with a bunion and asks how she got it. What should the nurse include? Good job, guys. All right. Good job, Tay. JJ. And Jean. Awesome job, you guys. Very good. And special shout out to Sol and Ray. All right, guys. Thank you so much for working with me through some technical difficulties. I really do hope, aside like all things considered, that you enjoyed the setup of having time for content and then having time to practice. Let me know if you did like it so I can kind of incorporate it in the future, or if you kind of liked how last exam we did some stuff, did some case studies, then did this. Just let me know. I will be sharing the recording with you guys as well as the link for this Kahoot. You're probably going to get that from me sometime tomorrow, probably during my office hours tomorrow. I have them from like 12 to 2. So that's probably when I'll upload the stuff and send the stuff. So you probably won't get anything from me tonight. But yeah, I really do appreciate you guys. And I really do hope this was helpful. If you need anything, you have my email, phone number, all of it. Message me in the group me, whatever you guys need. I'm here for you. And good luck with Sim Labs tomorrow. I know some of you going to Sim. Very exciting.